hereby open this academic session in which Nadine Doetsch will defend the academic thesis, The Impact of the Great Recession and Fiscal Policy on the Effectiveness and Accessibility of the Portuguese Public National Health Service and its Most Vulnerable Users. Subtitle, Demand for the Improvement of Healthcare Systems Resilience in Light of the Upcoming Crisis Events. Wow, what a title. Are you ready?
Yes.
Okay, may I then invite you to present a summary of your study and the conclusions of your thesis. The floor is yours.
Thank you so much, the Prorector. Thank you all for being here. I'm very happy that you're here in present and also online. And I'm very happy to share with you a very short and brief summary of the research that I conducted in my thesis. So the PhD was supervised by Professor Nadine Doetsch from the Institute of Public Health from the University of Porto. He's present online, where I also worked at the Institute, and externally supervised by Professor Thomas Kraft and Professor David Townend online, which are from the Care and Public Health Research Institute of Maastricht University. Thank you. The PhD was embedded within the European research infrastructure, which included one national project, the Mambina project, and two European Horizon 2020 projects, the You Were Healthy project and the Recap Preterm project. So I would like to invite you to imagine you live as a foreigner in a different European country. I'm using the fictional example of Hannah and her family, who moved from Poland to Portugal in 2008 to demonstrate my thesis. Hannah recently had a preterm baby. She's 17 years old. And her family, her mom, she's a nurse, who takes care of her mom, an elderly person who is in need of dialysis every second day, so a chronic patient. And when in 2009 the Great Recession, also called the 2008 financial and economic crisis, hit Portugal and Europe, Hannah's family found themselves in a vulnerable situation. Although crisis events occur frequent, neither adopted strategies nor protective or preventative policies are present at the national or international level in order to alleviate the risks to adverse health outcomes and to guarantee healthcare system resilience. So the resilience of a healthcare system can give insight into its ability to prepare for and to perform and manage and learn from shocks. And the resilience has to be analyzed by considering contextual characteristics, since it appears in a specific political and historical context. So the theory behind the thesis is that health inequalities affect or are rooted in the differences in access to resources, which is the result of power relationships and political and ideological decisions. So this illustrates that the social terms of health, public health, and population health are interconnected, and they influence each other. So looking at this interplay, it allows us to address major prevailing issues in the healthcare system and its most vulnerable users. But so how can we achieve resilience? The European Commission communicated that actions in research on healthcare system include the strengthening its effectiveness, increasing its accessibility, and improving its resilience. So the aim of this thesis is fourfold. I analyzed the macroeconomic impact of the Great Recession on the effectiveness of the Portuguese NHS, which was measured through mortality rates associated with socioeconomic indicators. I analyzed the impact of the Great Recession and fiscal policy on the accessibility of the Portuguese NHS for vulnerable population groups. I analyzed how to improve the healthcare system's resilience by proposing research opportunities and generating comprehensive cross-national data for vulnerable populations, and to discuss the next steps for policymaking in light of upcoming crisis events. I used Portugal as an example country, as it's one European country that was severely affected by the crisis, and I compared with other European member states in order to place results into a European perspective. I focused on the Portuguese National Health Service, abbreviated as NHS, and it's the public segment of the Portuguese healthcare system, which delivers patient-centered, public, and universal access to its users. Coming to the results. The impact of the Great Recession was confirmed on the effectiveness of the Portuguese NHS, taking recurring associations between the macroeconomic cycles, variations in mortality trends, stagnation of mortality, and macroeconomic volatility, which refers to debt aid, to account. I found similar results when I looked at Spain, as well as Greece and Italy. Findings also validate the association of perinatal and infant mortality with socioeconomic indicators, demonstrating a widening gap in inequalities and stressing the need to strengthen social protection policies in order to better protect population's health from the earliest days onwards, like Hannah's child. As effectiveness and accessibility are interrelated to provide high quality of care, I looked at the second step and I measured the accessibility to high quality care impacted by the Great Recession and fiscal policies on the adult population across the European member states. Coming to the second point. And the findings document increased risk rates of reporting unmet healthcare needs affecting especially vulnerable populations, such as Hannah's family, when specific safeguards were not in place. So therefore, I chose to look at different vulnerable population groups in order to examine vulnerability at different scales in Portugal, following a life course approach. Looking first at older persons like Hannah's grandmother, the impact of the crisis and fiscal policy on healthcare access was perceived as inadequate in approachability, appropriateness, availability, as well as affordability, leading to a deterioration of accessibility to the Portuguese NHS. Hannah's grandmother also mentioned barriers, which were, for example, related to finances, to waiting times for consultations, as well as to elective surgery, and availability of care services. So austerity policies seem to have overlooked an already very fragile population group and has not yet received a sector-wide response. So in order to receive a multifaceted view of care provision, it is crucial to also include the perceptions of providers. So I looked at healthcare providers providing high-quality care to healthcare access. And I looked at the quality of care for very preterm infants, which was assessed by different healthcare providers, such as nurses, for example, Hannah's mother, who used to be a nurse. And it revealed that although participants like Hannah's mom did not perceive that the quality of care deteriorated, as they gave their best to provide the best care possible, the analysis of their accounts of work revealed that it was indeed adversely modified in all of the WHO quality standards. An example is deteriorated functional referral systems and a lack of competent and motivated human resources, causing, for example, brain drain. Results also revealed that a comparison between healthcare users and providers' assessment may reveal a more objective assessment. So I developed a self-assessment tool comparing the migrant pregnant woman, such as when Hannah was pregnant with her child, with gynecology department directors, which were in charge of the care at the maternity units that the healthcare users were using. And I compared healthcare quality and healthcare access. So I found significant differences between the rating of healthcare quality and healthcare access, and as well as across the different regions of Portugal and across the directors' sex. So identifying these discordances delivered insights into the existing barriers and raised awareness, which is essential to inform practices and policies and to improve quality assurance. The existing barriers included issues, for example, in the collaboration, integration, and communication between the different healthcare sectors, which stressed the need for comprehensive, timely, efficient, and accurate patient and organizational data for research at the individual and populational level. However, data from vulnerable population groups are difficult to achieve as they are hard to reach groups, and therefore attrition in research studies is high. So, what enhances research participation of these vulnerable populations in research studies? I compared the motivations and deterrents to the participation of individuals born very preterm, like Hannah's baby, and healthcare providers, as well as the parents of very preterms. I looked at 8 cohorts across 7 European member states. And I want to highlight the results on the motivations to participate, which included the sense of solidarity and gratitude towards the care provided, revealing the interrelation between healthcare provision and participation in research studies for parents. The challenges for healthcare providers, especially for researchers that I want to highlight, are the funding of research projects and the issues in connection of data. So the connection of data, or also called record linkage, it's an alternative to retrieve population-level data by avoiding to invite, again, vulnerable population groups. it brings us, however, to consider the Privacy and Data Protection Law, the GDPR. So I conducted a legal comparative cross-country analysis of the GDPR's implementation and its connected national regulations, purposing record linkage of routinely collected data and data collected through observational population-based cohorts for health research in Portugal and other 3 member states. And I found that even though the GDPR is the most important legal framework, national legislation matters most, as the GDPR offers flexibility in its implementation. So given this flexibility, the results recommend that more harmonization of data protection requirements across the European member states could be helpful to facilitate record linkage, but should not be detrimental to those member states who already opened a leeway for research for the public good without explicit consent. So these results led to consider the next steps for policymaking, highlighting the necessity for forthcoming research in light of upcoming crisis events. So events of crisis can be of different nature. They can be political, they can be economic, like the Great Recession, or a health crisis like COVID-19, and therefore they require different governmental responses. They are different. However, their multifactorial effects on the performance of healthcare systems exhibit several symmetries. For example, which populations are hit the most, like vulnerable populations, and that digitalized information systems can contribute to advance the knowledge on the association between, for example, patients like Hannah's grandmother who are suffering from chronic diseases, and social or socioeconomic indicators addressing health inequality. So the results highlight the importance of interconnected patient and organizational data, which are part of the preparedness of a healthcare system towards a new crisis event, creating health equity. But so what can be done concretely? The best way to break out of this never-ending cycle of health inequalities is, as I analyzed through the life course approach, is by giving every child, like Hannah's child, the best start in life. Therefore, I suggest the next policy steps, which are comprehensive healthcare coverage by decreasing or eliminating user charges to remove healthcare access barriers, addressing austerity response, holistic and community-based care packages during the maternity period to address health inequities and decrease perinatal and infant mortality death rates, appropriate level and sufficient distribution of human and physical resources, which allow for increased capacity and provide the necessary flexibility, alternative and flexible approaches to delivering quality of care, to initiate innovative programs such as teleconsultations, a robust and flexible and well-motivated workforce who are well supported in order to avoid, for example, brain drain, redistributive policies in order to push families with young children, like Hannah's family, above the poverty line, for example, through paid parental leave, as well as nurse monitoring in the first months of life. Effective information systems and flows, which are at the core of decision-making throughout any policy process in the early stages of a crisis event. And lastly, record linkage of cross-divisional data, in line with WHO's call for science, solution, and solidarity, for example, like federated learning techniques. So, to conclude, the thesis confirms the adverse effects of the Great Recession and austerity policy on the effectiveness and accessibility of the Portuguese healthcare system, highlighting the necessity to rethink austerity policy as a response to economic crisis events. The thesis confirms the long-lasting debate about whether the healthcare system makes a meaningful contribution to population health, like Hannah's family, the importance of data as the next steps for research and health policy for healthcare system resilience, so to enhance participation and harmonize record linkage. And lastly, the need to break out of the cycle of vulnerability, building the basis for a functional, effective, accessible, and resilient healthcare system with an outlook to prospective steps in policymaking for future crisis events. So this was a summary of the research that I conducted in the thesis, and it's a summary of the framework that I developed from health inequalities to health equity. Thank you all for your attention, and then I'll give back the word to the prorector.
Thank you very much for so eloquently summarizing your thesis. We will now start with the questions. I would advise you paranyms to sit down because they already had their workout given the heaviness of your thesis, so please sit down. It's more convenient. It looks a bit empty, but everyone's here. But a number of people are online, and you already saw them, so we're very pleased to have them. And it looks like you only have one supervisor, which is not true. the rest are online. I will introduce them to you because then you have some idea. So Professor Thomas Kraft, who is a professor at the Department of Health, Ethics and Society from this university, is here. And his co-supervisors are Professor José Díaz Pinto de Barros, who is online with us. He's a professor of epidemiology from the Instituto de Saúde Pública da Universidade do Porto. And we also have co-supervisor Professor David Townend, who is a professor of health and life sciences, and he's at the moment based in London. Welcome both, and thank you for joining us. Now, given the breadth and width and depth of your thesis, a number of people want to talk to you. So it's my pleasure to introduce Professor Chabanovska. She is the chair of the assessment committee, and she's a professor of public health leadership and workforce development at this university. Thank you very much, and the floor is yours.
Thank you, Prorector. It is my great pleasure to talk to you today and ask questions as an opponent. Thank you very much for this interesting and robust thesis, and I would like to congratulate you and your promotion team for delivering such a good product for science. But nevertheless, I have some questions to ask. My first question is directed to the quality of health care systems, and you mentioned this in your introductory chapter, where I'm happy to see that you relate to a very famous direction-setting and prominent publication, Crossing the Quality Chasm by the Institute of Medicine. It has been cited many times, and it really sets the direction for healthcare systems. It shows here in your thesis the 6 pillars of high-quality healthcare, such as safety, effectiveness, patient-centeredness, timeliness, efficiency, and equity. While you discuss these aspects, there are also other very important aspects mentioned in this report that relate to healthcare, health, and public health workforce, how they are going to work together in an interprofessional way, and also there is a strong call for leadership that can only move the workforce to go outside the silos. I do not see in your thesis a strong relation or a call for the workforce. If I don't, how would you explain what workforce or how public health workforce and health workforce can best benefit from the results of your thesis, and how the healthcare systems can be advanced based on your results, including the interprofessional collaboration of workforce and development of leadership? That's my first question.
Thank you, dear highly esteemed opponent. Give me a few seconds to organize my answer to you. So you relate to Table 2 on page 30 to the 6 pillars of high quality of healthcare. And indeed, they are from the Institute of Medicine, and they are one of the most important pillars to quality of care, as they are interrelated, such as the effectiveness, patient-centeredness, and equity. It was the reason why I chose it. So when you go one page earlier, where I explain why I focused on the effectiveness, as well as on the effectiveness, the accessibility, and the resilience of the healthcare system, I interrelate the 3 points of the pillars, for example, effectiveness, patient-centeredness, and equity, to the Portuguese healthcare system. The Portuguese healthcare system is a patient-centered healthcare system, and every healthcare system should promote equity. And relating to the European Commission call for focusing on research on healthcare systems, I related these 6 pillars to the work. So going to the background section, in order to explain my point better, on page 38, I use the figure, the relationship between public health, social determinants of health, and population health. So that means that these 3 pillars are interrelated based on Shi et al. And with my thesis, I add the additional point of health research and health policy to this figure. And when I look at the choice of the population health, public health, and equity, it's reflected in the methods that I chose as well. So why I focused on quality of care, why I focused on accessibility.
Can I add
Yes.
one more question?
Yeah.
So what does it mean for health professionals, for workforce?
Mm-hmm.
What they can learn, what they can improve based on your results?
Mm-hmm. So you're relating to the impact of the quality of care. So I think that healthcare professionals, when I used this framework, the idea was to incentivate action with it. The quality of care is a part of the whole framework that I created, with the idea to propose policy and action. So specific points, I think that that are related to the question you had. I think the target group of, for example, the healthcare professionals is the need to focus on the patient as not as a common good or as someone who's using the services, but something interconnected. The quality of care is something that is profound. It's one example that I used with the definitions. Of course, as you mentioned, there are many. But I think the aspect of having the patient using the service that is not just seen as a commodity, not someone who's just using the service, but someone who can actually benefit from the results. And I think the second part you ask, so how can the healthcare system advance? I think it's interrelated in the framework that I used. So I think that the additional definition of quality of care that I used from the WHO, the 8 pillars, in addition, are several very specific steps. So they focus on the effectiveness, they focus on how to go a step further. So yeah, I think that would be my answer.
Thank you. I will have time for one more question. All right. The second, thank you very much, the candidate. The second question relates to the improve the resilience of healthcare systems part of your thesis, where you have 3 different studies that relate to understanding the participation in the cohort studies, how participants of the cohort studies feel, what are the barriers and facilitators to participation, and the last one is about data linkages. I would like to ask you how the policymakers can learn from these studies to improve or to recommend the steps to improve the resilience of the healthcare system. And why such a choice?
Thank you, dear highly esteemed opponent. I will take a few seconds again.
Yes, give a short answer, please.
Yes.
So the resilience is a concept, as I mentioned in the very beginning in the introduction, And I addressed it through those 4 studies, focusing on the WHO strategy for IT and infrastructure systems that was proposed in 2020. That's why my focus is very much on participation, on trying to enhance data, and in order to have access to individual and population level data, and connect this data in the second 2 studies of record linkage. So that's why I tried to focus, given also the importance of the GDPR, given the crisis, given the importance of the call for science solution solidarity as well, I focused on the parts of on IT systems, yes.
Thank you. Thank you.
Thank you very much.
Thank you very much. Then the opposition will be continued online by Professor Bauers. He's a member of the assessment committee, and his expertise is a professor of health economics at the Institute Nova School of Business and Economics at the University of Lisbon. Professor Bauers, may I give you the floor?
Okay. Thank you, Pro-Rector. And dear candidates, first of all, congratulations to you on the quality of your work. It was really impressive, and it is a very well-crafted series of studies, and I pretty much also enjoyed your presentation. It was really very good way of wrapping up all the studies that you have done. I think it's really good. As any stimulating work that you may create, it often raises kind of questions for us to further discuss with you and take this advantage of being in this committee to take you to 2 questions. And later on, if you want, we can discuss more of it in the future, of course. But today 2, and one of them is going to be of more detail, and another one will be a more general one. Okay. So the detailed question I have for you is on study 6, on the migrant pregnant women access to care. In that case, in that study, you consider 2 groups of women, migrant and non-native, and they were answering your questions after a live birth in a public maternity, if I understood well the design of the study. Now, my question is, can you have already some sort of selection bias in there? If you consider that migrant women may have more barriers of access to a maternity, then you could have some sort of selection bias. It may be present or not may be present, or may be irrelevant if only small number of women do not go to maternity. But I would like to hear you on this issue, whether this could be a problem, whether you thought about it, whether it is not a problem because you solved it somehow. What will be your reflection on this part?
Thank you, dear highly esteemed opponent. So on study 6, I compared, study 6. I compared the migrants using the facilities with the healthcare, the gynecology and obstetric directors. And you asked regarding the migrant barriers and regarding the selection bias, correct? If I understood correctly.
Yeah.
Yeah. I think as the study took place in Portugal, and we have a very specific population of migrants, it's very different, for example, to relate it to different scenario. In Portugal, the migrant group that I had, they had, for example, no barriers in terms of language, which was for me something that I was not expecting, because the majority of the population came from PALOP countries or from countries where they spoke at least English. So the majority of migrants did not have barriers. And regarding the issue, of course, to prevent barriers, the system that we used had 22 languages. So in case there was a language barrier, at least in terms of the migrant-friendly questionnaire, when they could express themselves, they could express it freely in their own language. Regarding the comparison, you said that, if I understood correctly, there might be a selection bias of the migrant population. I'm not sure if maybe you could repeat that part. It was a bit difficult to understand.
Okay, sorry. I'll try to be closer to the computer then. My point was there, if the ones that have more difficulties in accessing the maternities are the ones that will be more vulnerable, then you kind of have a selection against those that you interview. The ones that you interview will be the ones that, having access, will have a more positive view about the system than the ones that eventually didn't have access to it. And so the question was whether this selection could affect the perceptions that the ones that responded have relative to the whole target population that you could have. Of course, if you tell me that you're capturing 99% of the bursts, then it's not a problem. If you're telling me that you're capturing 75%, then it may be a problem. That was the idea of the question.
Okay, thank you very much. Yes, so in the maternity units, we invited 31, which is 80 and 82% accepted. So we have a huge variety of maternity groups, almost all. It's 82% in the mainland. And regarding the population, we had 5,687. So it was a huge population of migrants and native women. And I think that you are right with the fact that, of course, those who are responding are usually the ones that you could already reach. So that's true. I think, however, that the migrant-friendly maternal care questionnaire assessed almost everyone. It was, of course, it's hard to access everyone, but I think they assessed over a time period that was before birth until the postpartum period, so until 42 days after birth. So they had a long period of time to ask the questions. They had a chance to address the majority of the people. It's a huge cohort. It's a long study from 2007 until 2019, so they had several attempts to contact the persons. But I do agree with you that usually those who are answering are those who probably have a better view, or at least they are the ones who could access the care services. So surely that's a limitation maybe. And however, it's something that is very hard to address.
Okay, thank you. Now let me go to the second question. And for the second question, I will go to study 12 on the recommendations that you have there. As you could expect, since I'm coming from health economics, I would look carefully on the recommendations. Now, you have one recommendation that says that you recommend appropriate level and sufficient distribution of human and physical resources, allowing to increase capacity and provide the necessary flexibility. Now, if I haven't read anything about your study, I could immediately agree with this recommendation because it's actually quite general and it's difficult to say, why couldn't I agree with it? So in a sense, sounds kind of too general. But now if I go in more detail, you have there a term that makes me wonder what you mean by it, which is necessary flexibility. What does it really mean to you? And does it mean that you, for example, are advocating for a larger role for specialist nurses, as it is sometimes discussed in several countries, including Portugal? Or what is the meaning of this necessary flexibility, and how does it relate to the idea of resilience? So how to make operational your notion of adequate necessary flexibility?
So regarding the distribution of the recommendations of the appropriate level of distribution of resources and physical and human resources. So I think one of the issues that was implemented with austerity measures was the reorganization of primary care units. I mean, you are very well aware of this. But I think that what they tried to aim when they realized, okay, there are not enough GPs, for example, family doctors for the participants, for the users, they tried to enhance that, and they did in 2014. However, when we talked with the different patients, they were still not enough. So as it's a patient-centered healthcare system that in Portugal that uses the gatekeeping system, you first go to the primary care and then you are related to the secondary care and so on. And what happened very often that even though the users, they were exempt, I only looked at the users that were exempt from those co-payments, they were very fragile because of the crisis. So they had much less money to attend services. So the issue was, for example, for elderly to actually use different transportation to attend the services. So that is a barrier that is indirectly connected. So regarding the flexibility, it's an issue that patients are not always able to use the services. Either they have too few money to actually still use the service, or the healthcare professions are just not available, or they're concentrated in those areas where, for example, not so many vulnerable populations are. As, for example, in the migrant study showed, they are more in the outer regions where there are less primary care units, for example. So in terms of the flexibility, that's one part. I think, for example, during the COVID crisis, flexibility would mean to have teleconsultations, which took part. They were telephone consultations and so on. But I think the need that was there could not be fulfilled totally. So I think it's not a criticism, it's a recommendation to enhance, for surely not only for Portugal.
Okay, but let me just be more precise. Do you see a role for specialist nurses on maternal health to be expanded in Portugal?
I don't understand. Could you please repeat?
Okay. Could you see an expanded role for specialist nurses on maternal health in Portugal? That could be one of the meanings of flexibility that you mentioned. Could be just a yes or no answer.
I think a huge issue was the brain drain of professionals after the crisis. So I think it's one of the main issues in order to start with those who are most in need, the early children that are very young. It's to have especially nurses and doctors in the maternity care units. So I think that many had to, for example, work in private as well as public institutions together, as there were cuts in the pensions and so on. Many professionals left early in order to not have those cuts in their pensions. And I think it's one particular need that is related to the austerity measures, that there's a particular need for those professionals for Portugal, yeah.
Professor, thank you very much.
Okay, thank you and congratulations again.
Thank you.
Okay. We continue with the next opponent, who is also online, Dr. Borrell. She is a medical doctor and also member of the assessment committee, and she is from the Health Agency of Barcelona. Dear Dr. Borrell, the floor is yours.
Yes. Thank you very much and good morning. I would like to start making congratulations to you and your supervisors. I think this is a very good dissertation, and I think that today is an important day for you. Therefore, I think that congratulate is very important. I said in my report that I've never seen such large dissertation, 12 articles. That's a lot. That's a lot. I'm not used to this. I don't know if in this country this is general, but at least in my country, dissertations have 3, 4, maximum 5 articles. And I think that this large dissertation has the disadvantage in this case to include too many topics, because some of them are not so well related. And for me, I would prefer a small number of articles, but more related with the topic of financial crisis. In this case, I think that this is the main topic, although there are others related with methodology and related with other aspects, then I'm not sure that they add in the dissertation related with financial crisis. Probably this could be more deepened, and in order to try to understand a little bit more and not to be so large. Yeah. Well, this is a general comment, but my questions, I will make 2 if I have time. The first one is related with the conceptual framework of figure 4. I think it's, I have here, I don't know the page, but I suppose you know the page. Page 58. Page 58. Some aspects that for me are missing, as for example, the welfare state. I know that healthcare system forms part of welfare state, but other aspects of welfare state can be related also, and the expenditure on welfare state, for example, or labor market, also it's important, policies, macro structural policies on labor market, or, for example, when talking about access of inequality, for me it's important gender, because gender inequalities also are important in healthcare access and healthcare quality. I don't know if you have any questions on that, or I understand that conceptual frameworks are complex and there are many things that can be included, but I would like to have your opinion on these aspects.
Thank you very much, dear highly esteemed opponent. So with regards to your question on the framework, yes, I do agree. Frameworks are always very complex. Maybe it was not too clear, but I explained in the background section all the sections of the framework, including the section of the socioeconomic and political context, which actually includes the welfare state and as well as the policies. So I do agree that it might not be visible and that, of course, raises questions. However, in the background section, I explained it, and I think it's a very important point. Of course, I depicted in the framework only those points that I see as most striking, considering the context of the study. And regarding to the part what you mentioned of gender inequality, yes, it's a very important issue. I totally agree. In fact, I tried to select several population groups in order to address different aspects of vulnerability. That's why surely the studies might be different. They might address different groups. I tried to address the life course approach, meaning I address populations that are younger, older, in the middle age, different perspectives as well, because I think the healthcare system always needs different perspectives in order to measure it. But I do agree that the aspect of gender is not very visible in the vulnerable population groups. I do address the aspect in the study 7 when we relate to the participation. If you need to know exactly the page, I would need to look. But we say that there's one person who says that it's neither male nor female gender. It doesn't reveal the gender. And I'm saying in the conclusions, in the recommendations, that it might be important to address those population groups as well. Of course, gender inequality can go in different directions. It can be through women and female and male, but also different aspects in addition. Regarding your comment of the study, I do agree. It has a lot of articles which might not directly see the different connections. I selected them on purpose to include all of those, because especially the part of study 7 to 10 that you mentioned, it's the part that I think is the most important part, in fact, because they talk about data, they talk about how to connect data, how to enhance data. Without data, we can't do research. And I think the most important call that we have after the crisis, of the different crises that the WHO gives us, is to invest in data. It's the new call for the European data space. It's several calls. How can we achieve more resilient healthcare system? And I think that's the key point. It's, of course, to analyze what happened, but also and to look at the different population groups. But then how can we enhance data? How can we look at this problem, not only in a crisis that was in the past, where we can learn a lot of lessons, but also in any future crisis? I do agree they're different, but I think the similarity is the fact that the cycle of vulnerability will always be the same. And I think that's an issue that we need to address no matter when. And I think that's what I tried to do in order to add the part of the COVID crisis. I agree it's very different. It's a demand and supply side crisis, has different aspects. But I think the issue stays the same and probably will always stay the same. So I think that's our duty to address that.
Thank you. My second question is related with Articles 1 and 2. The fact that to analyze perinatal mortality, I think that it's difficult because sometimes rates are so low that it's difficult to go to decrease. They are difficult to decrease because they are so low. In the case of Spain, we have less than 5. And then it's, I think that cannot be increased easily. And this is one aspect. And the other aspect is refer to the validity of the data. We have seen in Spain that, for example, perinatal mortality is not well declared because we don't have the death certificate for them. This will change. This will change in the near future, but we don't have, and that's not so easy. And some of them are not declared. Therefore, there is an infraestimation. I don't know if you have thought about this. I don't know if in other countries it's the same, and how this can influence the results of these articles.
Highly esteemed opponent.
Can you give a short answer?
Okay.
Sorry. Yep.
Thank you. Okay, so a very short answer. I do agree that perinatal mortality rate has these disadvantages. That's why I used 2 different types. I used also infant mortality rate, as it, however, is very connected to the external factors. Perinatal mortality rate gives us a bit of a less connection with these factors. And it also gives us some more insights into the quality of care provided. So I on purpose did not choose the DALIs also because of the nature of the study. I think, in order to be very short, I think that the 2 indicators enable the best way possible to analyze the effectiveness for Portugal, considering previous studies also to allow a comparison, and in order also to allow a comparison between the different countries. I checked several studies which used also infant and perinatal mortality rates, among others. I looked also at mortality, maternal mortality. I looked at a lot of indicators. Actually, I looked at all of them. However, issues are that they are not available sometimes at a NUTS2 level. So I think that's another issue that we have, is the data availability, which brings us again to the question of data. But yeah, that would be my short answer.
Satisfied, Dr. Borrell?
I think that I don't have more time.
Don't have any more time. I'm very sorry. But thank you very much.
Thank you.
Then the opposition will be now continued on site. After this kind of Eurovision event, we now go on site. Professor Nijhuis is the next one who is going to ask you some questions. He's a member of the assessment committee and secretary of this committee, and is emeritus professor of obstetrics at our university hospital. The floor is yours.
Thank you, Mr. Prorector. Dear candidate, first of all, congratulations for your work, and of course, I extend my congratulations to your supervisors. Yeah, there's not so much time, so I would start asking you whether one of your paranymphs could read out quality standard number 7 at page 151.
For every woman and newborn, competent, motivated staff are consistently available to provide routine care and manage complications.
Thank you very much. Yeah, the impact on perinatal health is important, and I saw that your study 1, this weekend I saw it, is now published, not under review anymore, it's published in the Lancet Regional Health of Europe. Congratulations with that as well. But I looked through your thesis and I looked for the words centralization and decentralization. 6 times centralization, 1 time decentralization. That's not much, but it's a crucial item, isn't it? What is best for healthcare? How does it work? Are you in favor of centralization? Sometimes you say, well, centralization constrains accessibility. So what do we need in Portugal and the Netherlands?
Thank you, the highly esteemed opponent. In order to answer quick, so yes, you're very right. Both aspects are very important. I think, unfortunately, in public health, we cannot give mathematic answers, 1 + 2 is 3. It's more like, how can we achieve a 3 out of different ways? But I think that both aspects are important. So when I talk about the austerity measures, I think I'm criticizing a lot in my articles, which I stand for. But of course, they also had good points. And I think sometimes I can recall in one study, which is study number 3, we say that in Spain, for example, the austerity measures actually did not cause a decentralization, they caused a centralization. That was probably the aspect that you meant when you said, I say it one time, the centralization. So there was a law in Spain, to be very short, in fact, that the different pharmaceuticals, pharmacies that are selling pharmaceuticals suddenly had only access to those in public, meaning that sometimes different users went to different pharmacies and they didn't have this medication because only particular pharmacies could access them, which, well, it was a centralized approach, but it caused the opposite. So I think both aspects have its advantages and disadvantages. I unfortunately cannot give an answer to what's the best.
Okay, but let me then extend my question a little bit. Because of this quality standard 7, in the Netherlands we have a lot of small hospitals and we have big hospitals. And we have a higher mortality after 37 weeks when all children are delivered in all sorts of hospitals. Tavares, a Portuguese colleague of yours, published in 2017 a study in Porto, it's not part of your thesis, where he showed that if the medical staff is present 24/7, then the data improve enormously, and then there is no day-night difference. For example, in the Netherlands, I know that in a lot of hospitals, after 6 o'clock, the lights are off, the anesthesiologists go home, there's no epidural, the medical staff, obstetricians are at home, and they can be called, yes, but that's about it. So I think this Tavares study is important, and that's part of centralization, decentralization. So what do we do?
Yeah, I think with regards to Portugal, in that relation, I see it both ways. Because yes, when healthcare professionals, as that colleague mentioned, are available 24/7, they not only focus on one patient probably more, meaning they can provide the best care possible as they know exactly what happened. They don't have to brief someone else. But I think that it also causes tiredness. It causes mistakes. So I think it goes both ways, again. But I think that the closing, for example, of the different maternity units in Portugal had a very beneficial effect. It reduced the mortality rates. But on the other hand, it also increased the difficulties in access, meaning some people have to travel a long way in order to, for example, I know a case, had to travel from a very small town in the north of Portugal to Porto. So being in labor or being in the very, let's say, if everything goes well, okay, but if not, if it's a preterm baby or if it's something that you do not expect, yeah, it's probably not best.
Life is difficult, I understand. Thank you very much, and I give the floor back to the prorector.
Thank you, Professor Nijhuis. Then the opposition will be continued by Dr. Clemens. He is also a member of the assessment committee, and he's an assistant professor at the Department of International Health of this university. The floor is yours.
Thank you very much, dear prorector. Dear candidate, I would like to pass over my congratulations as well to you, to your supervisory team, and as it is good custom in the Netherlands as well, to the family. So I think there's a beautiful achievement that has looked very thoroughly into the financial crisis, and it has reminded me as well that we had quite some crises afterwards in terms of the refugee crisis, Brexit, climate change, COVID, and I think your work addressing the financial crisis has certainly learnings for other crises as well. So thank you very much. But I'm not here just to congratulate you, but I would like to exchange on a couple of aspects of your work as well. The first one is your theoretical framework. I think it's very encompassing. I like how you have been using it to steer the different individual analysis, particularly in the dimension of performance and accessibility. I think you nicely tap then with your single studies into various dimensions in these broader categories. I see a difference with regards to the resilience dimension. You refer to the 15 strategies of colleagues from the observatory, Thomas and others, and you are nevertheless focusing on a single of these 15, namely infrastructure and IT, with regard to your work around record linkage and participation in cohort study. Can you explain to me what have been the reasons to depart from the strategy of in the other dimension and here focus on a single dimension around infrastructure and IT?
Thank you, dear highly esteemed opponent. It's a very fair comment. I think that given our situation with what's happening politically, I focused on what I found was most important, not only for Europe, but also for Portugal, because Portugal tried to enhance their participation in digital health a lot, as well as other European countries, and we are on the verge in maybe 2024, 2025, depending, of the start of the European health data. So everyone has access to the data, hopefully, and I think that we are living in a very different time as 10 years ago when the European and economic crisis happened. As you mentioned, several crises that are currently happening that are we are expecting to happen very soon. I focused on the IT infrastructure, and it has some subpoints, so I focus also on the subpoints of that strategy, but overall it's the IT and infrastructure because of exactly our political situation. I think that currently it's the most important point to enhance data access in order to prepare healthcare systems. Without data, we can't do so. And I think especially why I tried to focus on the vulnerable populations, it's those that are the hard-to-reach ones. So I tried to look at different strategies across several countries, using several cohorts, using the most important, the GDPR, in order to have and continue the patient's rights to their data, which of course is a very important aspect of the whole data availability, if not the most important aspect. But that's why I tried to focus on that. I think it's, from the thesis, those are the studies that I think for me, as I mentioned, are the ones that are the driving force, because they are the ones that, though they might be limited to the part of IT and infrastructure, and surely if I would have more time, I probably would have done more studies, but unfortunately I didn't, but yeah.
Let me rephrase as well, or put another aspect to that dimension. To me, obviously, data is something that we will be using to improve our system to the future. But let's say in terms of resilient, data doesn't bring nurses, doctors to the bedside and doesn't provide services immediately. And particularly, I like that you as well mentioned the economic adjustment programs to Portugal. Putting them in perspective to the 15 strategies, I mean, they address pharmaceuticals, they address primary and hospital services. And yes, you could argue this is not resilience, this is immediately austerity measures. But I think if you look down in these dimensions, there are aspects in these economic adjustment programs that address strengthening the resilience. So once again, how do you look at these other dimensions that as well are blended in Thomas and et al. Resilience strategies?
Yes, thank you, dear Helio Pund. Very good point. Yes, data does not give us actually a resilient healthcare system, but it gives us the ability to analyze the healthcare system. So when you mentioned, in order to be brief, the part of the economic adjustment program on page 40, which I explained in different studies more into depth, Unfortunately, it was not visible probably in the thesis because they are available online as supplementary material. But you are very right that the economic adjustment program already addressed several points that are in need for the resilience. So the restructuring of the primary care services, the enhancement of generic medication of pharmaceuticals, and the hospital care services. So I think that very true, these aspects are.
You may finish
My sentence.
the question and the answer, or you may forever remain silent. It's up to you.
I will try to finish shortly. Thank you. So yeah, these points are, of course, they were very well thought through. I think it's not just a random austerity policy. No, for sure they are thought through, and I think they did make sense. I think what was the issue? Maybe the European Commission did approve them, but they did not analyze the consequences previously, which they did in, for example, other studies, other programs that they implemented. So I think that was one crucial issue. But I think also that it's not always possible. So I don't think it's the fault of the European Commission. Of course not. I think the issue is more that sometimes we don't know what's going to happen in the different healthcare system. Thank you.
Okay. Dear candidate, the time has passed for your defense. The committee here present will now withdraw to review the quality of your thesis and your defense. I want you to remain here with your company and await our verdict. We'll return shortly. Okay?
Thank you.
Thank you. Dear candidates, dear Julia, the degree committee here present has assessed the quality of your thesis and your defense. In view of its very positive verdict and taking into account your previous qualifications, the degree committee has decided to grant you the degree of doctor. Professor Kraft is authorized to confer upon you this academic distinction in accordance with Dutch university custom. I invite your supervisor to now take the floor.
All right, please.
Dear candidates, congratulations. You promise to work in accordance with...
Please use the microphone.
I think it's, yeah, I don't know.
I will use it in a minute. Do you promise to work in accordance with the principles of scientific integrity at all times, to be careful and honest, transparent, independent, and responsible?
Yes, I promise.
Then, by the authority vested in us by law and in conformity with the decision of the committee here present, I hereby confer upon you, Julia Nadine Doetsch, the degree of doctor and grant you all rights attached by custom and law. As evidence of this, I now present you with a degree certificate signed by the rector, the secretary, and the other members of the committee and affixed with the official seal of the university.
Go there and make a picture.
Take your time for a picture.
Yeah, yeah.
Where we agreed that all three of your supervisors would briefly address you and also the audience. And I would ask my colleague, David Townend, to go first.
Thank you, Thomas. Dear Dr. Doetsch, Julia, how good it is to be able to call you by your new title. It says to the world that you are an accomplished researcher, scholar, academic, able to see interesting situations, assimilate available materials, evaluate them from a range of perspectives, not merely your own, identify methodologies to answer refined questions, execute those methodologies, gather data, analyze those data through different theoretical perspectives, and then present them cogently to different audiences, and then start all over again, because you've unearthed a whole new set of interesting situations with new questions that you're desperate to answer. Although perhaps you don't want to think about having to go through all this again today, of all days. And what a fabulous dissertation you have produced. It is, I believe, of the very highest standard. It's undoubtedly a topic of great importance. It's an important question to ask with so much resonance in so many societies. For me, one of the most impressive parts of the dissertation is just how many parts there are. Your dissertation comprises original work in so many different projects, and all of such quality. The papers, so many more than the norm, are all published, and all fascinating and valuable contributions to science. And equally impressive is the framework you've developed. This is a real contribution to science and to policy. And it's a beautifully written thesis. The quality of the thesis is also reflected in the variety of interesting questions it stimulated from your opponents today, and congratulations on the wonderful way that you handled those questions. All of this, of course, reflects your diligence, your imagination, your inquisitiveness, and your exemplary hard work. So today marks the end of a really great chapter, and it's time to write the next of, we hope, many more exciting chapters. This Maastricht chapter has been a long one. You studied for your bachelor's degree, your master's degree, and now your doctorate. And we hope Maastricht will appear in the next chapters as well, and that you'll continue your links with us. Today, you can be rightly very proud of your work and your achievements, as can your family and friends who've supported you in your journey. Congratulations on your wonderful work and your fabulous defense today. I'm sorry I can't be with you. I hope you have a wonderful rest of the day.
Enrique?
Dear Dr. Doetsch, dear Julia, I think this is a very relevant moment in your life course, and it's a wonderful moment for all of us because you finally have been recognized by this assessment committee as somebody that even before what you recognized when receiving your diploma, to be ethical, to be transparent, to be professional, to be able to work by yourself, to use your imagination, and to serve health as a human right. Everything was in your work before during these years, and what you achieved with all these published papers that are the backbone of your thesis are in fact outstanding. It's impressive, and I think you deserve all the recognition for that. First of all, I'm really sorry I cannot be with you in Maastricht, but I hope we can meet soon. So the only thing I would like to tell you is that this is, you opened the door, if you allow me to say this way. Congratulations for that, to you, to your family and friends. And I hope that now that the door is open, you can achieve all your dreams in research, in working in health, because you have the skills, you have the knowledge, and you are such a hard worker that you deserve to be really somebody in the field of public health. I want you to congratulate again you for the work you have done, and I'm pretty sure that you'll do wonderful things in the future. Congratulations, Julie.
Thank you very much. I promised the pro-rector that we would be very quick, so I will try to just give 3 words, 4 words to the not only brilliant candidate who received her doctoral degree today, but a very fun person, witty person, and caring person that I had the privilege to work with during the entire period. You started here in Maastricht. I had you already as a bachelor student. I worked with you as a student in global health, and now also as your supervisor in the thesis. And I must say I've enjoyed every day really working with you. It was really fun. We have met at many places. I've also seen how much you have really adjusted to the culture in Portugal, that you not only care theoretically about patients, but really engage in interacting with people and the population. And you had also phases where you were really sick yourself, you had really to suffer, and you have overcome this. And I was really very much impressed by this. I know that you want to take a break, but I do hope that you come back to academia, because this is really, you have the potential, obviously, and it would be really a shame if you would not want to continue and contribute further. Thank you very much, and congratulations.
Thank you so much.
Congratulations on behalf of the university as well. You were here a student in EPH and Global Health, and then doctorate further. And it's kind of funny to see that Professor Kraft has been, or is your doctor father, and he probably seen him more than your real father, so that's always interesting to see. From the comments that you got, we were really impressed. A very, very, very good thesis and an excellent defense. So, and we could also see that you kind of loosened up along the way and got less stress and got more fun in doing it. So congratulations on a job well done. You're now an alumni of this university that never goes away anymore. Even if you do 10 other doctorates, this is the first and the most important one. And also the research school, CAPI, wants to congratulate you with this accomplishment. Now, we almost close this session, but before we do, we have a number of announcements. One is we will make a picture of you, your para-nymphs, and the rest of the committee in front of this screen, because all the opponents are here as well, and I want to thank them also for being here and asking these wonderful questions that made you shine. Then we go to the stairs, where we make another picture, and then we go for refreshments to the rafter. Don't worry, follow us, and you'll get drinks and other stuff that will happen itself. So with this, I close this session.